Paris năm 1993, giáo sư Yves có thâm niên gần 30 năm nghiên cứu và giảng dạy trong lĩnh vực y học bào thai. Ông là giáo sư chuyên ngành sản phụ khoa, trưởng khoa sản và y học bào thai tại Bệnh viện Nickel Enfant Malade và Đại học Paris. Ông còn là giám đốc của chương trình thạc sĩ quốc tế chuyên ngành sinh lý bào thai và bệnh học bào thai và chương trình quốc gia chuyên ngành siêu âm sản phụ khoa. Giáo sư nổi tiếng với phát triển phương pháp phẫu thuật nội soi ít xâm lấn cho bánh nhau đơn của hội chứng chuyển máu song thai. Tại khóa đào tạo lần này, giáo sư Yves sẽ chia sẻ kiến thức và giảng dạy xoay quanh 3 chủ đề: thoát vị hoành bẩm sinh, các trường hợp phẫu thuật khó ở song thai một bánh rau, đánh giá trước sinh về thai nhi bị nhiễm trùng.
Vâng, xin cảm ơn. Và bây giờ tôi sẽ nói về thoát vị hoành bẩm sinh. Một cái tình trạng thai những cái đã chỉ ra rằng là những cái can thiệp vào thai có lợi ích. Và đây là những cái bước mà chúng ta cần phải hoàn thành.
So, congenital diaphragmatic hernia is an embryological defect of the diaphragm. Can happen anywhere, and it can also be without a diaphragm, and those are dreadful conditions. But the most common place is the left side of the muscle. And the final problem is not the malformation itself, but it is a malformative sequence whereby the abdominal organs moving up into the fetal thorax are going to compress the lungs, the heart, and the vessels, and particularly affect the vasculature of the lungs through at least 3 mechanisms. One is by compression. The other one is hemodynamically, because it is compressing the heart, and it will cause an abnormal shift between the left and the heart and the right part of the heart, and also through pulmonary hypoplasia. That is, the lungs are prevented to grow in a large part by the compression, and also by some
là một cái cơ chế nội sinh mà gây ra các cái bất thường về cả mạch máu. Và vì vậy cái chẩn đoán của
difficult parts, but what remains to be assessed before you embark into surgery is, one, if the abnormality you're looking at is isolated or not, and two, you have to look at prognostic factors. And those prognostic factors are mainly, once again, with associated problem, and I'll come to that in a minute, but also on your assessment of the potential for the lungs to grow. And if the diagnosis is usually made quite early, at the time of second trimester detailed anomaly scan, by seeing the herniated organs, and especially in a case of a left malformation like this one, with the up move of the up stomach next to the heart, then the prognosis on lung growth is usually more difficult, and optimally has to be done later on at around 26 weeks or 26 weeks onwards to have a fair assessment of the potential for the lungs to grow. Okay. So first, the association, and it's not fortuitous it is not rare. More than a third of CDH are associated to either abnormal chromosomes, but as for cardiac defects, as Dario told you, a karyotype is not enough when you investigate congenital diaphragmatic hernia. You have to go through an array or even push that even forward, and you will hear about more sophisticated and thorough genetic examination in relation to malformations with the next talk by Mark Kilby after this one. So there are many conditions. The heart can be affected, but it can be affected and a concern only if it's a cardiac malformation associated with the hernia, because the hernia itself is going to push the heart, make it look asymmetrical, but this asymmetry is not a significant one after birth. And Dario did not even mention this one because it's not a cardiac malformation, but there can be cardiac malformations, obviously, associated with diaphragmatic hernia, and it can be anyone, any of the malformations could be present. So assessing the lung and the potential for the lung to grow after birth relies primarily on ultrasound. And again, there is no point to look at the lungs at 20 weeks. 20 weeks is for diagnosis. Between 20 and 26 weeks is for investigation of associated problems, and prognostic evaluation of CDH starts at 26, 28 weeks. By that time, you would measure the lung that is contralateral to the hernia. And therefore, in the most common forms, you will look at the right lung while you have a left CDH. And the best method, the most tightly correlated with the prognosis, is to measure that lung that is remaining and apparent in between the vertebrae, the auricles, and the lowest rib by measuring by two perpendicular diameters, the largest two perpendicular diameters of this lung tissue. And you put that as a ratio over the head circumference. And this simple, not to say simplistic measurement, but it has to be done properly, like every other measurement actually, will show a good correlation with survival in left-sided congenital hernia. It is useless in right-sided congenital diaphragmatic hernia as a prognostic factor. And then you have to move to MRI to evaluate the lung volume, and MRI assessment works just as well as lung to head ratio in left and in right diaphragmatic hernia. And in terms of survival, correlation with survival, MRI, fetal MRI is superior to the lung to head ratio. And it is expressed in relation with gestational age for obvious reasons, which are that the lungs are growing, and even hypoplastic lungs are growing with gestation. So you have to use formulas that compensate, that take into account gestational age, and even better, fetal weight. And that's what MRI does. Now, coming to the management, once you've clarified the issue of associated anomalies and you are pretty sure meaning that even when you've done all the work at birth, about 5% of these babies will show weird figures that you had not anticipated and will necessitate even more thorough genetic investigations. But let's assume that this form is isolated. When you look at the history of how to manage and try to salvage those fetuses and babies to be, this was actually at the origin of the foundation of the Fetal Medicine and Surgery Society, somewhere, I told you, in the US in 1982. And this has gone through numerous experiments animals, and especially the sheep and the fetal lamb, have paid a huge tribute. It's probably the hugest herd of sheep that were killed to manage the management of congenital diaphragmatic hernia in humans. And not surprisingly, people from New Zealand were very much ahead of everyone else in these experiments. But it was all for nothing, and it was quite moving when Michael Harrison in 2003, and therefore 20 years of his life. Michael Harrison is an emblematic pediatric and fetal surgeon, the pioneer of fetal surgery. He spent 20 years of his career to try and mimic pediatric surgery into the fetus, to end up in 2003 in one of these meetings in IFMSS to say, I was wrong, it doesn't work. And then came what finally led to a treatment that is effective, which was to observe a deadly condition in utero called chaos. Chaos is a complete obstruction of the airways of the fetus, through which the lungs are literally blowing up with fluid, because when the trachea is obstructed, the lungs are producing growth factors and fluid that are inflating and boosting the growth of the lungs. But of course, because it happens from the embryonic period and up to the time of the fetus or the neonate dies in chaos, those lungs are useless because it is too much pressure and for too long. But this gave the idea to a Canadian team in Quebec to temporarily obstruct the trachea for 1 month, for 6 weeks, depending on the severity of the examination of this lung hypoplasia, and then remove the obstruction so that you boost the growth during the fetal life and you decrease, at least theoretically, initially, the risk of deadly pulmonary hypoplasia. So the procedure has gone through several improvements, and I'll show you where we are now. Where we are now is that in utero, you're going to use a semi-curved endoscope, the same one as you use for laser in cases with an anterior placenta. So it's a 1.3 to 2 millimeter endoscope in a curved sheath. And before you get anywhere near the fetus, you're going to give this fetus anesthesia and paralysis. So we use, as Mark said, we use the pacluronium or Norcuron, 0.2 milligram per kilo, and we mix that with fentanyl, so morphine basically, 10 micrograms per kilo, and we give that either in the umbilical vein or intramuscular. IV works quicker and for a longer time. So if that is something that is not too technically difficult, it is better. And then for the mother, the most difficult part is to position the fetus looking at you, so to speak, or looking at your ultrasound probe. So that is the most painful part for the mother. And that's the only reason why we really recommend an epidural for this procedure when those fetuses with anterior placenta are ill positioned. Then the version is not that easy and can be quite painful, especially with the stress of the procedure surrounding this woman. Apart from that, the aim is to introduce this cannula with the scope that is holding an operative channel through which a small embolization balloon will be passed and inflated in the trachea just above the carina. So you have to intubate, literally, the fetus. So the first step, and I insist on that, is to anesthetize this fetus and also to stop the fetus move, especially to stop the fetus swallowing, because if the fetus is swallowing, however skilled you are, you will never go through the trachea. You will end up in the esophagus every single time. So that's the anesthesia. Then there is either epidural or local anesthesia for the mother, and you introduce your trocar at the level of the eyes of the fetus. So not in the eyes, please, but at the level of the eyes, so that you see the nose and you see the eyes, so that when you will get there, you will be theoretically just above the mouth or at the level of the mouth, and you will be in the position to see here. Here is the tongue. You have to go above the tongue, not below, but below you will quickly realize you're not at the right place. Then you find the palate, and this is the epiglottis that you have to go above and find the entrance of the trachea, not going into the esophagus. That was the first orifice we saw. These are the vocal cords, and then you just push some fluid to open them, and you get into the trachea, and you're going to push and inflate your balloon above the trachea, about 1 centimeter above the trachea. If you go too low, the risk is to block one main bronchi and not the other one. It's not a major issue, but it's better not to. And then you leave that balloon here. After 6 weeks, most cases are done following exactly the same way. Usually the fetus is bigger 1 month later, unless you have to do it as an emergency a few hours later, then that's not a good scenario. And you will find the trachea a bit more easily, but still the same gimmick. You go above the epiglottis, and you would see the vocal cords, and usually it is more open at this stage. So you would deflate the balloon and grasp it with a forceps. You could also aim for ultrasound-guided deflation. It is not as easy as it could be, because 6 weeks later, usually the position is not favorable for that. There are vessels nearby that you better avoid. You can also be faced with rupture of membranes and a woman in labor. There is no reason to do an emergency section. It could be an exit procedure with a vaginal delivery, depending on what the position and what the plan is and what the speed of labor is. Exit procedure, meaning whether it is vaginally or through cesarean section, getting the head out, but only the head, not twisting the neck, because otherwise the procedure is going to be very complicated. And in the kind of emergency, often the neck is a bit twisted and makes the procedure difficult. And then either using the same instrument or pediatric instrument, depending on the size of this neonate, you would extract the balloon before getting the baby off the placental circulation. It is not a very sophisticated exit, as sometimes you do with pediatricians rarely do for sacrococcygeal teratoma or cardiac intervention. It should be a quick procedure, so you don't need extra anesthesia to the woman. Can be done on just spinal anesthesia. Now, I told you that for left diaphragmatic hernia, the lung to head ratio, LHR, in the x-axis, observed over expected, so corrected for gestational age. The prognosis was the survival was very dependent upon the lung development. And the second most important prognostic factor is whether the liver is partly up or completely stays intra-abdominal. So you've got the combination here. The white bars are liver in the thorax, and the blue bars are liver down. Obviously, liver down have basically a better prognosis, but combined with the LHR, you will define severe or extremely severe forms with an LHR of less than 25%. Between 25 and 45%, you have a moderate form in terms of survival, and a mild, which is into inverted commas because no CDH is mild. It's always a severe disease, but in terms of lung development, call it mild. And therefore, the target for prenatal diagnosis is those severe or moderate forms, but the severe forms and the moderate forms have been subjected to studies. And I will give you the results I probably read of the 2 New England Journal papers on randomized trial of fetal surgery for moderate and for severe congenital diaphragmatic hernia. So to summarize the moderate ones, the procedure was performed at about 30 weeks because the aim there is not really to expect initially an improved survival where the survival rate is already above 50%, but to decrease the postnatal complications. And the postnatal complications are very significant. They are significant in terms of respiratory problems and assistance. They are severe in terms of pulmonary hypertension. And also, although not vital, they are very significant about the oral development of these babies, both by feeding, by speech, and interaction with others. So the key word here is time. It takes a very long time for those babies, if they don't die, to get to a normal life, but they eventually get there. But it takes years. And that's an essential part of the counseling. So it was done at 30 weeks, and the balloon was removed at about 34, 35 weeks. And you see that although this is not strictly significant in terms of p-values, there is an increase in survival in those moderate forms of about 25 to 30%. So it's not only the morbidity, and when you look at combined morbidity, there is a benefit of that. The drawback is that if you compare the group that had a surgery with that where you didn't do anything, obviously only in the group where you intervene, you have a risk of prematurity. And that is the main problem with all fetal surgery, but rupture of the membranes happened in nearly half of the cases, and it was significant in terms of preterm birth in 60% of the cases. So this is an important part to take into account, especially depending on the neonatal resuscitation resources available and the pediatric surgery as well. Now, this randomized study was the biggest and probably the more rigorous, the most rigorously done, but there were others before that have shown, especially in severe forms, that it was meaningless to offer just expectant management to those extremely severe forms. There were observational studies, there were meta-analysis, and all of them reported an increased survival by fetal surgery, using fetal surgery, about 10 times, 5 to 10 times the natural history. The natural history of survival in severe forms is 5 to 10%. And all the previous studies showed that in severe forms, the survival was up to 30 to 60%, even in severe cases. Now, it's survival, it's not morbidity, I agree, but that's what it is. There was even a randomized study that showed that, but for some reasons, there was some persistence to go down the road with this international randomized study, and not surprisingly, when you operate on fetuses with an LHR of less than 25%, you operate earlier because you want to boost the lungs as much as possible. So the intervention is at 27, 28 weeks, and you leave it for 6 weeks, same thing. And survival here was 40% in the fetal intervention group compared to 15%, which is already quite a good figure, 15% in the severe cases. But these were done in expert centers. Expert centers doesn't mean, yes, it meant also expert in fetoscopy, but it meant mainly expert as a perinatal team, because you can change dramatically the survival, whether you operate or not, doesn't really matter, but the survival is dramatically different in a perinatal team, and mainly neonatologists, who follow rigorous same protocols, individual care, and especially in the management of pulmonary hypertension. So neonatal care, there is a center in Germany, in Mainz. They have an 75 or 80% survival in severe forms without surgery. That's what they claim, and I'm keen to believe them. But again, the gain you had on survival, you obviously have the black side of it, which is prematurity, and again 47% prom rate compared to 11% and 75% birth before 35 weeks. So it does benefit to those fetuses who survive prematurity, in case of prematurity, to be operated in utero. Randomized studies have come to a limit in fetal medicine where you should not force anyone getting into a study because these women have the right to terminate their pregnancy or to carry on with their pregnancy, but sometimes are denied the treatment option, and that's not fair. MRI volume is more accurate than LHR, and there is a specific case that is about 5% of those congenital diaphragmatic hernia, where the diagnosis is usually made in the 3rd trimester or at birth. Babies at birth are not that bad, and especially if you were to calculate this lung-to-head ratio, it would be absolutely normal in the 3rd trimester. And that's where the hernia, although significant, is contained in a sac, a peritoneal sac. And so far, only MRI can reliably make this diagnosis. No invasive procedure is necessary in terms of treatment, and the prognosis is really excellent. Now, the last update is something still investigated. It is a balloon that is carrying a magnet, and this magnet is susceptible to the MRI wavelength around the MRI, the magnetic field, and it could be deflated by just for a woman to walk around the MRI in the MRI room, and that could deflate the balloon. So that would spare the second part of the procedure, which is to deflate the balloon. Now, the main advantage of that is that if a lady is referred for a procedure in an expert center and then comes back to where she is followed and she will deliver, and this place can handle pediatric surgery, then she doesn't need to go back and get the balloon out, providing there's an MRI around. So that would be a big step, but for that second part of the story. So the message is, I repeat, first and foremost, make sure this congenital diaphragmatic hernia is isolated, or otherwise, I think that would be an option only for expectant management or for a compassionate care or termination, obviously. And 2, in the assessment, don't jump on the assessment of the lungs at 20 weeks. That's useless. Wait until 26, 28 weeks. Which is anyway the right time to decide on an invasive procedure. But so far, this procedure should really be carried out only in centers where not only the MFM is skilled to do it, but the neonatal environment is fit to take care of a baby with pulmonary hypertension, and in 70% of the cases, delivery before 34 weeks. Thank you for your attention.
Vâng, chúng ta lại tiếp tục trong phần hỏi đáp ạ. Xin mời quý vị chúng ta đặt câu hỏi cho giáo sư Vin. Xin chúng ta đặt các câu hỏi khẩn trương ạ, bởi vì thời gian cũng đã tương đối muộn rồi. Các thầy cũng khá là mệt và chúng ta cũng hơi bị kéo dài thời gian. Xin quý vị đồng nghiệp chúng ta khẩn trương đặt câu hỏi.
That's a lunch break. Yep. The joint Q&A session.
Ở các đầu cầu online, quý vị đồng nghiệp có câu hỏi gì không ạ? Xin đẩy lên hộp chat ạ.